Welcome, everybody. Today's webinar is on From Complication Prevention to Functional Optimization, an overview of supportive treatments in multiple myeloma. We are very lucky to be joined by Dr. St-Hilaire, who joins us from the Dr. Leon Richard Oncology Center in New Brunswick. Veronica and I have had the pleasure of hearing Dr. St-Hilaire speak specifically on this topic. It is a fantastic presentation, and we are very grateful that she has taken the time out of her day to be with us today to share this information with all of you, to allow it to be recorded and available on our YouTube channel. Dr. St-Hilaire, I'm going to stop sharing my screen so that you can begin to share your screen, and we'll make sure tech is working wonderfully.
Thank you for the kind introduction. And thank you for the invitation and welcome everyone. So in the next 45 minutes or so, as Chantal said, we will review supportive treatment in multiple myeloma. So that includes talking about the prevention and treatment of disease manifestation, but also about the treatment toxicities. So I have no conflicts. So I will focus a lot on the bone disease since it is one of the main manifestations of myeloma affecting a lot the quality of life. So a big part of the presentation is to discuss about bone disease, but we will also address a little bit about neuropathic pain, thrombosis, anemia, infection prevention, gastrointestinal toxicity from treatments, and emotional health. So over the last years, we have seen a lot of new medication being approved in Canada and around the world for multiple myeloma. I started to work in 2007, and we were just starting to be able to use lenalidomide in Canada. But since then, we have had several new medication, new class of agents that we use in combination. And the beauty of having more treatment options is that we are able to achieve better responses and better duration of response, and that translates into an improvement of the survival rate. So here's just to show, for example, like the blue line here, you see the survival in the 80s. Was around 22 months, so not even 2 years. And if we look in the last 10 years, that translates into a survival around 8 to 9 years. And it's probably better for lots of patients. However, even if we've made lots of improvement in our therapeutic option, it doesn't always translate into an improvement on the quality of life. And even though we can help the burden of symptoms when we treat the disease, we also create new toxicities with our treatments that can affect the quality of life. In the literature, among hematological cancers and even cancer in general, myeloma is associated with the greatest symptoms burden. So I'll start with the bone disease. I will use a lot the bone manifestation. I just want to show you a few examples of what we find in the bones of patients with myeloma. So those are just simple x-rays. There is here you see like a hole in the bone, like that dark spot here shouldn't be there. Same here on this x-ray of a pelvis and femur, you see like a lytic lesion here. So that's what we mean by lytic lesion. It's really a bone resorption, like a destruction of the bone that will create holes in the bones, and that will cause fragility that will lead to increased risk of fracture and can cause pain, obviously. So at diagnostic, by imaging, about 80% of patients will have bone disease visible, and it continues to increase along the course of the disease. So that's the reason why during the baseline evaluation, we will always actively search for bone disease with scans or MRI to determine if somebody has symptomatic myeloma, if somebody needs active treatments. It is associated with pain in about 60% of the patient at diagnostic. And the problem related to the lytic lesion or the weaker bone is what we call the skeletal related events. So patients are at increased risk of bone fractures, and depending where are the fractures, it can also lead to neurologic damages. So I will discuss more about that in a few minutes, but there's a complication we call spinal cord compression, which is related to fractures that will happen in the vertebra in the spine. Of course, the bone disease has a negative impact on quality of life because it's the cause of the pain, and also has an impact on physical capacity. So patients can be limited in their personal care or their daily tasks because they cannot stand long enough, they cannot walk long distances because of pain. So it is it has a huge impact on quality of life. One other problem we see in myeloma is the development of osteoporosis or osteopenia. So it basically means a decrease in the bone mineral density, and that can also increase the risk of fracture. So I don't want to lose you in details here, but just quickly to explain how it works, like the bone remodeling, because the treatments we give to prevent osteoporosis, they kind of target these cells. So we have two types of cells in the bone. We have the osteoblasts that are bone that are there to produce bone, and the osteoclasts that are resorbing the bone, so destroying the bone, basically. In a normal situation, there's kind of an equilibrium between the two, but in multiple myeloma, the myeloma cells and other cells in the marrow will increase the production of rank ligand, which is a kind of a protein that will stimulate the osteoclasts and therefore promote bone resorption and will decrease the bone density and create these lytic lesions. So on the side here, I just showed a dramatic example of a fracture. So I'll address the bone disease in two different ways. So I'll discuss about the prevention of osteoporosis and fracture, but I'll discuss later about the treatment of fractures, especially in the spine and cord compression. So there are different medications that have been studied to help to increase the bone density, but the ones we use the most in clinic are zoledronic acid or Zometa and denosumab. And so I'll focus on these last two trials here because the previous ones here are older and we are not necessarily using these agents anymore. So in the Morgan trial, that's what we call the MRC trial, patients with myeloma, newly diagnosed myeloma, were randomized to receive zoledronic acid intravenous or clodronate, which was an oral form of bisphosphonate. And they showed that the patients who were treated with zoledronic acid had less skeletal-related events, so meaning they had less fracture, less core compression, and also had a better survival. In that trial, patients were allowed to be put on the trial even if they didn't have visible bone lesions to start, but the vast majority of the patient had something on their imaging, 73% of the patient. The second trial, RAGI trial, compared the zoledronic acid with denosumab. But in that trial, all the patients had to have at least one visible bone lesion on their imaging. And they showed a similar efficacy in reducing the skeletal-related events and no difference in survival. So it means that zoledronic acid or denosumab are quite similar in terms of efficacy. So the International Myeloma Working Group recommendations therefore include these two in their most recent recommendation. So everyone with a newly diagnosed myeloma or starting back treatment because of a relapse should be treated with a bone protecting agent. The first option is the zoledronic acid. And based on the trial data, it's regardless of the presence of bone disease or not. And the denosumab, if we follow the way the trial was done, is only for patients with multiple myeloma-related bone disease on imaging. There's also some other differences I will underline in a minute. They still list pamidronic acid here, but it's not often used in clinical practice. So the denosumab, it's an injection that can be given subcutaneously. So that's one advantage of it. And the other advantage is that it can be used in a situation of kidney failure. So if somebody has a bad kidney function, denosumab can be given. However, it has to be given every month. And if we stop, there is theoretically a possibility to have a rapid decrease in the bone mineral density. So it's recommended not to stop definitively, but to keep like a every 6 months injection. Denosumab is used to treat osteoporosis in general, not just related to multiple myeloma. So these data about the rapid decrease in bone mineral density are mainly in the population of patients taking it for osteoporosis. The zoledronic acid cannot be given to someone with a decrease in the kidney function. So here's just the level we look at. It's an intravenous injection, so meaning the patient have to come to the oncology clinic to receive it. We can space the injections to every 3 months or every 12 weeks, and it has been shown that it is equivalent to every 4 weeks injection. So in practice, we'll start with every 4 weeks usually, but after, let's say, months or 1 year on treatment, we will switch to every 12 weeks. It decreases the visits to the clinic for the patient. And it is recommended to keep patients on zoledronic acid for at least 2 years. Because the survival advantage I showed earlier has been demonstrated for the population of patients that were on it for 2 years or more. So, for example, if somebody has had chemotherapy followed by transplant and is on maintenance lenalidomide or other maintenance therapy and has had no disease progression after 2 years, we could stop zoledronic acid, but at progression, when we start back another active treatment, we'll have to restart the zoledronic acid. So that's usually what we do in practice, because unfortunately, these drugs, they have some side effect that I will show to you in a minute. We also recommend people to take supplements of calcium and vitamin D. At first, not always, because some patients will present with increased level of calcium, so we won't obviously add supplements, but along the disease, it's recommended to take the supplements, because even if you have osteoporosis and multiple myeloma, you can still have a certain level of bone formation, and these vitamins are important for the bone cells to produce new bone. There's also other risk factor to osteoporosis. So lifestyle modification can improve a little bit the risk of osteoporosis. So quit smoking, decrease alcohol intake, engage in physical exercises, not necessarily cardiovascular exercises, but really muscular exercises to increase the strength. That's what will increase the bone mineral density. One of the complications we see with the bisphosphonate, so zoledronic acid, but also with the denosumab, is the osteonecrosis of the jaw. So here on the picture you see, so it's basically a kind of an inflammation that will develop in the jawbone, and the patients will feel a pain. They will feel swelling, and we often see a piece of bone going through the gum. So the risk factor to develop that complication is to be on a long-term exposure of bisphosphonate. So that's one of the reasons why if we stop after 2 years, we can minimize that complication. People with poor dentition are also at increased risk, and any dental procedures during bisphosphonate treatment can also cause that. I don't mean dental cleaning, dental examination, but more invasive procedure like a tooth extraction, root canal. So it's really important to let us know if you have dental procedures to be done and you are on a bone protecting agent. How can we prevent that complication? So before to start zoledronic acid or denosumab, we will recommend to patients to go to see their dentist and have a dental examination. I find it's harder and harder to do since our dentists are really super busy now that we have more patients able to go and see the dentist, but it's still a recommendation. And we make sure that if there is any dental work to be done, we'll ask the dentist to do that and we'll start the treatment after that. And if somebody develops an issue with dental health while they are on treatment, if possible, we'll try to stop the zoledronic acid or denosumab for 3 months, proceed with the dental surgery, and wait another 3 months before to restart in order to decrease the risk of osteonecrosis of the jaw. So for the treatment of skeletal-related events, I'll focus on the vertebral fractures and complication. I just want to show you a little bit of anatomy so you can understand better. So here it's a cartoon showing you like the vertebral body. Behind that, you have the spinal cord. The spinal cord is where all the nerves from the brain will go down in the extremities. And the nerves will go out on the side and go like in the legs or in the arms. So that's what we call the nerve roots. If you have a fracture in your vertebral body, then a piece of bone can displace and push on the nerve root or push on the spinal cord, and that obviously will cause sometime pain for sure, but paralysis also. The other way we can have a vertebral complication with multiple myeloma is if we develop a tumor involvement of the vertebra. So sometimes in myeloma, we have what we call plasmacytoma. So it's basically a tumor of plasmacytes, and that can affect the bone, that can cause fracture, but also can give a soft tissue mass that will push on the nerve or push on the spinal cord. So the International Myeloma Working Group also have some recommendation or treatment algorithm for the vertebral complications. And it's basically to determine what is the problem. If somebody presents with severe back pain and neurological symptoms, we want to know, is it a bone problem or is it a soft tissue involvement? Because if it's a bone involvement, we often need surgical decompression, so we'll need to have a surgery. But if it's a soft tissue involvement, like the second picture I showed you, treatments can be helpful, like high-dose steroids like dexamethasone, radiation therapy, and even chemotherapy to treat myeloma. So that's what we do. So in order to know, we'll do imaging. So here are images of MRI, and that's the spine seen on the side. And if you see here, there is something abnormal. If you focus on that area, you'll see the vertebra is completely broken and the piece of bone is just pushing on the spinal cord. So this patient probably has leg weakness and cannot walk and stand up. So that's kind of a medical emergency to deal with that. So besides a vertebral complication, radiation therapy is also used to treat painful bone lesions. So if somebody started systemic treatment but still have lots of pain, we will refer to radiation therapy. It's quite effective, 90% chance of efficacy, and they only give 1 dose of radiation. In the past, we used several days of treatments in a row, but it has been proven that 1 dose is as good as a couple of weeks of treatment. And we will also refer patients for radiation if they have a big lesion that didn't cause a fracture yet, but is at risk of causing a fracture. Same thing for the cord compression, or if they have symptomatic plasmacytoma, those are the soft tissue mass I described earlier. We need sometimes the help of orthopedic surgeons, especially for the management of fractures or impending fractures of the long bones, like the femur, because those are weight-bearing bones, so meaning that you have lots of weight on the femurs when you stand up. So if you have like a big lytic lesion, you're at risk to have a fracture. So they will sometime do a fixation and prevent fracture. We'll also use the orthopedic surgeons to do decompression of a cord compression, and sometimes just to stabilize the spine if there are several fractures. There are techniques that are not as invasive as a surgery that can help to treat the fracture in the spine. There's the vertebroplasty and kyphoplasty. This can be done by surgeon, but we also have interventional radiologists that can proceed with these techniques. They are pretty similar. It's just that in the kyphoplasty, they will go in the bone with a needle and will inflate a balloon to give back the height of the fracture vertebra. And then they will inject surgical cement to solidify the vertebra. And in the vertebroplasty, they just don't use the balloon, but they use the same surgical cement. So that helps to stabilize the vertebra, not to fracture more. And it helps the pain a lot if somebody has severe pain from fractures. So there are also international myeloma working group consensus on the use of vertebroplasty and kyphoplasty, but it basically resume what I just said. So if it's refractory pain, significant symptom affecting activities, we have to think about it and not wait too long to do that. If somebody has had pain for 2-3 years, might not be the best candidate to do these procedures. We often need to use pain medication to help the pain control. So we'll use narcotics, either hydromorphone, morphine. Steroids work really good for pain and multiple myeloma. So all our treatments include dexamethasone. But sometimes if I see a patient is in a lot of pain, I don't have the diagnostic yet, I'm not ready to start treatment, I might use steroids alone, waiting for the treatment to start. We have to be careful about the use of anti-inflammatories, NSAIDs, because patients with myeloma have fragile kidneys, and NSAIDs can cause kidney failure. So we really rarely prescribe anti-inflammatories to patients with myeloma. If the pain is caused by a compression of a nerve root, the description of the pain will be different. The patients will say they feel like a shooting pain down the leg, a burning sensation. We might want to use different class of agent, not just narcotics. So that's where we'll prescribe pregabalin, some antidepressant like duloxetine, and cannabinoid drugs. So those are really better for neurological pain, and they can be combined with the narcotic and with the steroids. And for more refractory pain, we'll refer the patients to a pain clinic. Where I work, it's not necessarily the pain clinic, it's more like the palliative care clinic that will help us to manage the refractory pain. So now we'll go through the polyneuropathy. So the myeloma itself can cause polyneuropathy, but our treatments are mainly the cause of that. So by polyneuropathy, I mean a sensation of tingling and a decrease in the sensation of the extremities, hands and feet. It can be light and not affect the quality of life, but sometimes it can be quite severe and can be a reason to discontinue treatment. So the two class of agent that can cause neuropathy are mainly the immunomodulatory agents. In the past, we were using thalidomide that gave a lot of neuropathy, but now we use lenalidomide or pomalidomide. It's not as frequent. It's reported in about 5% of of patients, and it's severe in less than 2%. So that's a good improvement compared to when we had thalidomide only. However, the bortezomib or Velcade is often used in treatment regimen and will cause neuropathy. Again, when we started to use bortezomib, it was an intravenous infusion and it was twice weekly. And the rate of neuropathy was way more important than what we see now. So for many years now, we use the bortezomib under the skin by subcutaneous injections and only once a week. And the good thing about the neuropathy caused by bortezomib is that they don't tend to be chronic. They will improve in most patients and will completely resolve in 60% of the patients if we dose decrease or stop the treatment. So there's no miracle. If somebody starts to develop neuropathy on treatment, we have to reduce the dose. Sometimes we have to stop the treatment, and we use the same kind of pain management I've mentioned earlier. Now about the thrombosis. So thrombosis means blood clot in the veins or in the arteries. Multiple myeloma increases the risk of both venous and arterial thrombosis, but we have each patient will have additional risk factor for thrombosis. The older we get, the higher is our chance of blood clot. If we've had surgery, immobilization, previous thrombosis in the past, we are at higher risk. Obese people are at higher risk, and anyone that is not as mobile as it should is also a risk factor. However, our treatments, some of our treatments will increase the risk of thrombosis, and it is mainly the lenalidomide and pomalidomide. So depending which treatment we use, the risk of venous thrombosis is around 10 to 20%. So 20%, it's quite high. So there is a indication, therefore, for us to give treatment to prevent thrombosis when we use lenalidomide and pomalidomide in protocols. And the thrombosis we see the most would be blood clots in the veins of the legs or pulmonary emboli that can increase the morbidity, can even cause mortality. So it's certainly important to prevent. There's different medications we can use to decrease the risk of blood clot. We can use just regular baby aspirin. We can use injections in the under the skin every day. It's called the low molecular weight heparin. And we can also use oral anticoagulant. That's what I mean by DOAC. So those are newer drugs, if I can say. There's different stratification tools that have been published to help us to determine the risk of blood clot in each patient, but their performance can vary in different populations. So it's not necessarily always used in clinical practice. The most recent recommendations will favor the use of low molecular weight heparin or DOAC over aspirin, at least for patients at higher risk of thrombosis. So that is included in the most recent European Myeloma Network recommendation and the IFM group, which is a group from France. So I just put the IFM group clinical guidelines. So they say if somebody is on IMID, so IMID means lenalidomide or pomalidomide combined with dexamethasone. So if the answer is yes, if that patient has no problem with kidney function, no risk of bleeding, then they say consider anticoagulant prophylaxis. Prophylaxis means prevention. So they do recommend the injection or the oral anticoagulant. However, if somebody has poor kidney function, these two agents here are contraindicated. And or if somebody has a higher risk of bleeding, then we'll have to wait the risk and benefit and decide if we prescribe the prevention or not. On the other side, if somebody has no combination, like no IMiD, dexamethasone, or receives another kind of myeloma treatment, we don't routinely give prevention to everyone. It will depend on their risk of thrombosis. So lots of hematologists, including me, were mainly using aspirin as a prevention, but probably it's something will continue to improve and change, mainly to assess the risk of each patients. Now, to talk about the anemia. Anemia, it's a decrease in the red blood cells. It is one of the frequent manifestations of multiple myeloma. It's often when the patient, are diagnosed with multiple myeloma. They see their doctor, they're tired, they have a blood test, they see they have anemia, and then the test starts to be done. So 75% of patients with newly diagnosed myeloma will have anemia. It's either caused by the disease itself, because the cancer cells will replace the normal bone marrow cells. But we also have anemia if we have a kidney failure. So if somebody has kidney problem related to myeloma, the kidneys are producing erythropoietin, which is important to stimulate the bone marrow to produce red blood cells. So the lower is the kidney function, the higher the chance you're going to have anemia. And at the time of diagnostic, if we treat the myeloma, most of the time the hemoglobin improves and we have no specific treatment to give for the anemia. But sometimes, sometimes if the disease is more advanced, or if there is a concomitant kidney failure, we'll need to do something to treat the anemia. The first thing is the blood transfusions. The second thing we use are under the skin injections using erythropoietin stimulating agents. So basically giving that supplement of erythropoietin. And we don't want necessarily to have a normal hemoglobin, because if you increase too much your hemoglobin, you are at higher risk of blood clots. So you have to find the good target around 100, 110. That's what we try to reach. And sometimes it's just at the beginning of treatment, and when the myeloma responds well to treatment, we'll see an increase in the hemoglobin and we'll be able to stop that medication. But it's not used really frequently, but it's something that can help. Now on the infections. So myeloma also increases the risk of infectious disease. It is one of a major cause of morbidity and mortality. And it can be caused by the disease itself, because there is a decrease in the production of normal immunoglobulins or normal antibodies when we are affected by myeloma. But our treatments also decrease the immune system. So the worst period of time to be affected by infection, it's when we get the new diagnostic, so the first 3 months after diagnostic, or when we are treating a relapse or a refractory disease. So most infections are caused by viruses or bacteria. We see lots of influenza, RSV, COVID, and pneumonia, sinus, bronchitis. We can do things to help prevent these infections. So I will show you how. The first thing is the vaccination. So we can give almost any vaccines to myeloma patients except the live attenuated vaccines. Most of the seasonal vaccines we use are not live attenuated. The ones that are contraindicated would be the MMR, like the muscle, mumps, and rubella. I hope I say it right, because it's not the same in French, but MMR vaccine is live attenuated. There's an old shingle vaccine, Zostavax, that was live attenuated. But it's not the majority of the vaccines, but it's always good to check to make sure you can receive it. It's important to remember we respond better to vaccines when we are not on active treatment or facing an active myeloma. So that's one of the reasons why we'll try to vaccinate patients, if possible, when they are diagnosed in asymptomatic phase of their disease, while we won't wait for them to be ready to start treatment. But lots of patients come to us with newly diagnosed myeloma, which already need treatment, so it's not always feasible. And if somebody won't have a transplant, will just be treated with chemotherapy, we will recommend vaccines for pneumonia, the pneumococcal vaccine, the annual flu shot, the COVID vaccination. And I did put question marks for RSV and Shingrix because here in New Brunswick, it is not reimbursed by the province. And the RSV is reimbursed only for patients that are 75 or older. But if you're 55 and you have myeloma, you could still get the vaccine if you pay for it or if you have private insurance paying for it. But I don't know how it is in other provinces. So I do discuss that with my patients, and sometimes they have access through their private insurance. Sometimes they'll just pay for it. If you're a young patient, you go through transplant, or if you go through CAR T therapy, you need to restart all your vaccines. Like I say to my patients, they are like a newborn baby after a transplant. So you need to do like a diphtheria, tetanus, hepatitis B, the pneumonia. So it's a calendar of vaccination that lasts for about 18, 24 months. So that's the reason why I separated these two categories. If you live with someone with multiple myeloma, so you should also receive your routine vaccine, the flu shot, the COVID, RSV, depending on your age, to protect your loved one. And if you are living with somebody with myeloma and you get live attenuated vaccines, you shouldn't be in close contact with the patient for, I didn't find a range, but for a few days at least, just not to shed the or share the virus or the bacteria. And if you travel in foreign countries, just make sure to consult a travel clinic, because there are other diseases that can be different in different countries. The other way we can help to prevent the infections, it's to use a prevention with antibiotics during the treatment. So there's a trial here that was made several years ago where they took patients with newly diagnosed multiple myeloma, and along their anti-myeloma treatment, part of the patient received prophylaxis antibiotic and the other half didn't. And they compare the rate of infection and death in the two groups. And they saw, so here on the line, you see the patients who got the antibiotic had less fever and death than the patients who didn't took the antibiotic. So I wrote here the absolute difference. So it is something we can do, but when we start treatment for myeloma, we give lots of medication, like you have oral lenalidomide, you have medication for nausea, you have other prophylaxis that I will address in a minute. So sometimes it's just too much pills. And personally, I don't necessarily give it to all my patients, but I will assess if they are older, if they had recent infections, if they had poor dentition, because anybody with poor dentition is at increased risk of pneumonia. And I have had patients who had allergic reaction to the antibiotics. So it's good, but I wouldn't say that all hematologists are using it in all their patients. we use other prophylaxis depending on the treatment we prescribe. So we'll always give antiviral prophylaxis with valacyclovir or acyclovir if we use bortezomib, like proteasome inhibitor, bortezomib, carfilzomib, with the anti-CD38, so daratumumab, isatuximab, or if we prescribe the BiTEs. And after transplantation, we also give that prevention for 12 months after transplantation. And TMP-SMX or Bactrin or Sulfa, there's different names here you can give. It's given to prevent a type of fungal infection in the lungs. It's called pneumocystis. So it's a pretty bad pneumonia that most of the time will happen on patients with immunosuppression. So if you're healthy, you won't get that type of pneumonia. But with myeloma, because the disease itself and the treatment we give, some patients are at higher risk. So if you are treated with high-dose steroid, dexamethasone, you might have prevention with TMP-SMX prescribed. If you have a BiTE therapy, we give it to everyone. After transplant and CAR-T, we give it for 3 months. I put a question mark because the duration varies depending of the centers, like 3 months, 6 months. But there's way we can measure the immune system to know if it's safe to stop it. And if you have had a pneumocystis pneumonia, you'll need to continue that antibiotic for the rest of your life. And in case of recurrent infection and low level of a certain type of immunoglobulins, we call IgG, that's something we measure in the blood. We will also consider to give immunoglobulins replacement. So those are blood products that we infuse every 3 to 4 weeks in order to supplement in antibodies that the patient is no longer able to produce. And we use it all the time if somebody is on BiTE therapy as well. Because the BiTEs, they will give lots and lots of infections. So we are really aggressive in preventing the infections. So now I'll discuss a little bit about the GI toxicity related to the treatment. So as most people know, like chemotherapy, unfortunately, will cause nausea, diarrhea, constipation. So the rate of nausea will vary among the treatments we give. The treatment with the highest level of nausea in myeloma is the selinexor, but there's good ways to prevent it. So if you give the appropriate anti-nausea medication, it is well tolerated. And patients who go through high-dose chemotherapy for transplant will also have significant amount of nausea. So when we start systemic treatment, we'll always prescribe something in case there is nausea. But besides medication, there are some strategies to help, like, for example, eat small meals more often in the day. Stay hydrated, but not necessarily drink big amount of fluid at the same times. Favor dry food, eat food at room temperature. It sometimes decrease the nausea. Avoid greasy, creamy food, and avoid caffeine or anything that would promote acid reflux would help. For diarrhea, of course, it has an impact on quality of life. Some of our treatments, some patients will have severe diarrhea and will have a hard time to get out of their house. So what can we do for diarrhea? I mean, there's lots of things we can prescribe, and sometimes we have to change the medication. I'm thinking about lenalidomide, where there's many generic form. I have patients that are not able to tolerate a certain type of lenalidomide, but will tolerate the other one better. So sometimes we have to try and see. But in terms of strategies to try at home would be to sometimes modify the diet. Low fiber diet will help diarrhea. There's the brat diet, which consists on banana, rice, applesauce, and toast, which you cannot eat for days and days. But let's say you have treatment and you're going to have 2 days of diarrhea. Those that diet can be favored for a couple of days. Eat small meals and maintain hydration. We use ondansetron as an anti-nausea medication, but as a side effect, the ondansetron causes constipation. So it's something we can prescribe to help both the nausea and the diarrhea. We can also prescribe loperamide, but that can be buy over the counter as well. And I particularly like the bile acid sequestrant for my patients with lenalidomide-induced diarrhea. So there's different formulation. There are pills, there are powders. So that's something that works good. For constipation, it's often for many reasons why we have constipation. So it can be at presentation. If the calcium is high, calcium too high in the blood will cause constipation. You can be constipated because you have pain and you take narcotics. Narcotics will cause constipation. And the treatment itself can also cause constipation. So if you have constipation, we do prescribe medication, but make sure you hydrate yourself good because it will help, and eat a high fiber diet. So the last part is about the emotional health. So that's the only French slide I have. I didn't find the equivalent in English. So as most of you know, the myeloma will have like a remitting, relapsing course of disease. So you're diagnosed sometimes with myeloma that does not require treatment, like in an indolent form, but you live these years and you're afraid of becoming symptomatic and requiring treatment, but you don't know when it will happen. And then you have your treatment, it works, you're like in good remission, but then you fear the second relapse. So every time there is a relapse, it creates anxiety, and it exposes patients to new treatments. So these high and lows in the natural history of myeloma certainly affects the emotional health. So the psychological distress related to myeloma is related to the nature of the disease. So I've explained it about the relapsing, remitting of disease, but also to learn that it is an incurable disease is certainly a stressful situation. We often give chronic treatment, so our patients are on treatment until progression or intolerance, meaning that some of you are on treatment for years and years, and then you're exposed to these toxicities, and that can also cause some psychological distress. And the comorbidities, I mean by that, to live with the pain, or if you have anemia, you're short of breath, you cannot play golf anymore. So there are manifestations of the disease that will also affect the quality of life. And even patients that are not on treatment and don't have symptomatic myeloma, those that are diagnosed in the indolent form of the disease, can suffer from psychological distress because they fear the time when the disease will progress and they will need treatment. And in all honesty, the system we work in doesn't have a good capacity to offer psychological support as we should, at least in my center. So what are the causes of psychological distress identified by people with myeloma? They might feel a decrease in their life satisfaction. They can feel they are a burden for their family. They can live through financial stress because they cannot work anymore. They have to pay some copay for medication to part to the hospital. So the disease comes with lots of expenses. They might be able to unable to perform their daily tasks. They can have to manage new physical symptoms, pain, change in their body image. You lose your hair, you have vertebral fracture, your back is all round. So those are all new things we have to adapt to. And of course, the impact of treatments. So here it's a publication I find where caregivers were asked to answer questions about their level of anxiety, depression, and PTSD. And interestingly, the level of anxiety of the caregiver was higher than the patients themselves. The level of depression was a bit lower, but still significant, and they had the same level of PTSD. So it's just to say that it's a distress for the patients, but also for their family members. So in conclusion, the support treatments I've explained to you in today's presentation are really important in the myeloma treatment. We talk a lot about drugs and anti-myeloma therapy, but it's really important we offer also good support treatments. It helps to prevent complications. It can allow for a better quality of life. But I still think we need to improve our multidisciplinary approach to fulfill all the needs, especially the emotional distress. So that's the end.
Okay. Thank you, Dr. St-Hilaire, for being here. Thank you, thank you, thank you. For all of you who attended the webinar today, we are glad that you connected with us and that you were here. We hope that you stay connected with the myeloma community in whichever way fits you best. For those of you who are watching the recording in future dates on YouTube, we also hope that you found this useful. And again, Dr. St-Hilaire, thank you for being with us. We appreciate everything you do for the myeloma community. Wishing everybody here a wonderful 2026.
Thank you. Have a good day.